Right, let's get started. Good evening, everyone, and thank you for joining us in the next of our series of webinars from OCL Vision. My name is Purvi, I'm lead optometrist at OCL Vision. And to those of you that are joining us for the first time, a huge hello, and for those regulars, hello, and it's nice to see you again. This webinar is recorded and will be available to watch on our YouTube channel, OCL Vision, along with all our previous webinars. There is one CET point available for this webinar if you're watching it live from the link that you received when you registered. And it is for optometrists, dispensing opticians, and therapeutic prescribers. This lecture will run for 45 minutes with questions at the end. So if you do have any questions, please pop them in the Q&A box at the bottom of the screen, and we will get through as many as we can at the end of the lecture. So today's speaker, and backed by popular demand, is Mr. Shah Kashani. Shah is a consultant ophthalmic surgeon at OCL Vision, who specializes in the management of complex medical retinal disorders. He performs intravitreal anti-VEGF injections, intravitreal steroid implants, anterior and posterior segment laser treatments, as well as high volume cataract surgery. Thanks very much, Shah. If you'd like to share your screen, I shall pass it over to you.
I shall. Thanks, Purvi. As always, very kind of you to ask me to come back and do a presentation on uveitis. I know it's quite a difficult subject. So I'm going to put my timer on so that I know I'm keeping to time and I'm not going to have you guys standing around for too long. So uveitis. So the aim of this lecture is to just talk about different classification, pattern recognition. That's something I really want to get across today, because understanding inflammation and uveitis is all about recognizing patterns. And once you have a good experience with that, you can kind of try and arrange your treatment accordingly. Really, the other big question is, when do you need to start treatment? Of course, with a lot of these conditions, sometimes you need to investigate before you treat, and sometimes you don't have actually time to wait for these investigations to come back because the condition is affecting the vision irreversibly. So we'll talk a bit about that. Various investigations and treatment strategies, and actually a little bit about uveitis and COVID. So classification, well, there's three ways to classify uveitis. You can classify it anatomically, you can classify it based on etiology, and you can classify it based on type of inflammation. And that's quite important, actually, because when you're referring patients on to your local hospital or whoever that you refer on to, these are very important things that you need to mention in your referral letter. And the person who's triaging needs to know these things before they know whether they need to see the patient there and then that night, or it can wait till tomorrow. Most patients with uveitis need to be seen fairly quickly anyway, but it's still important to have. So anatomically then, you've got, you all heard of anterior uveitis. This essentially includes iritis or iridocyclitis, or some people refer to as anterior cyclitis. Intermediate uveitis, that's a term that's really reserved for vitritis, so inflammation in the vitreous, as well as peripheral retina, not posterior pole, peripheral retina and pars plana. And posterior uveitis, so that's anything in the back of the eye, including choroid or chorioretinitis or retinochoroiditis. Just depends where the inflammation starts, but it can affect the choroid, retina, or both of them together. And neuroretinitis, where the optic nerve is also involved. So that's posterior uveitis. And panuveitis, where you have inflammation throughout the eye across all structures with no predominant part showing up. So anterior uveitis then mainly affects the anterior segment. It's the most commonly seen intraocular inflammation. You tend to kind of see this in HLA-B27 syndromes, herpetic simplex and zoster infection, Fuchs heterochromic iridocyclitis, which is often unilateral, or most commonly actually post-operative. And really, when you see a patient with anterior uveitis for the first time, you must dilate the pupil in order to see the back of the eye, because you don't know whether, by definition, the vitreous, retina, blood vessels are involved or not. So, you know, if you see a patient with anterior uveitis and you haven't dilated them, you could miss out on some big stuff. Intermediate uveitis, as I kind of mentioned to you, is kind of more the middle portion of the globe, which includes the vitreous, peripheral retina, and pars plana. Postplanitis is another term that you may have kind of heard, and in that condition, you see snowbank and snowball formation, which I will show to you shortly. Intermediate uveitis is important because it's often associated with some major conditions such as sarcoidosis, TB, and Lyme disease. So a thorough history is very important. We'll get to causes in a minute. Posterior uveitis, as I mentioned, is inflammation of the choroid and the retina, and all these structures could be involved, or even the optic nerve. And in case of retinitis, for example, you might have seen this in acute retinal necrosis, as you can get in herpetic infections, or toxoplasma retinitis. Choroiditis tends to happen with inflammatory conditions such as syphilis, such as sarcoidosis, or infective conditions such as TB or syphilis. More unusual conditions which will affect the posterior uvea include serpiginous or birdshot chorioretinopathy. And finally, the optic nerve can be involved in various conditions such as toxo, bioretinitis, and lymphoma. So these are kind of just learning the anatomy. And panuveitis, as I mentioned, no predominant site of inflammation, but you can see it in anterior chamber, vitreous, choroid, and other structures can be involved. So when you're seeing a patient, you need to kind of try and locate it anatomically. And as you're locating it, essentially, are there cells in the anterior chamber? Is there any flare? Can you see any cells in the vitreous? You can generally do that by aligning the viewing part of the slit lamp with the light together, and you can just see cells in the vitreous, or you can actually do that by kind of separating them as well. So look for vitritis, and then look at the posterior segment. Is the optic nerve involved? Are the blood vessels involved? And look right through the periphery, because you might miss peripheral retinitis. Look at the blood vessels, look at the choroid, look at the retina. I saw a patient quite recently who was diabetic and referred to me for diabetic macular edema, and the person had written, stable PRP. In fact, the patient had never had laser treatment and the diabetes had just started. And what they were looking at were multiple choroidal lesions throughout the retina, which they thought was PRP scars. So simple history would go a long way to help you. So having decided where the inflammation is, and as I said, it can either be anterior, intermediate uveitis, posterior, or panuveitis, you're then thinking about various conditions that can cause inflammation. And in fact, by and large, it's idiopathic. So most of your patients, 30 to 40% of patients, will never have a cause. It might be a one-off anterior uveitis, or even in recurrent cases, you might not find a cause. But if they are recurrent, or if the posterior segment of the eye is involved, then the risk that this could be something systemic or another, or some sort of ocular syndrome goes up significantly. So we normally don't tend to investigate anterior uveitis when it's just happened once and there's no posterior segment involvement. But if the anterior segment, if the inflammation occurs again, or if there's any structures in the back of the eye that's involved, then they do need a very thorough investigation. But by and large, idiopathic is the commonest finding. And then you think about secondary systemic disorders, and it's very important to take a thorough medical history. So within the musculoskeletal system, do they have arthritis? Have they been diagnosed with anything within the bowel, like ulcerative colitis or Crohn's? Respiratory conditions such as sarcoid or TB can also point towards direction of what's going on. Other infections are kind of important. So viral infections, herpetic mainly, fungal infection, and parasitic infections can all cause inflammation as well. So, but we'll go through the history on how you can elicit those. Lens-induced, these are kind of the very unusual now, thankfully, hypermature lenses where you've got leakage of lens material into the anterior chamber causing inflammation, which requires urgent surgery as the pressure can go up. Traumatic, which can be following surgery, or non-surgical, head injury or football injury, things like that. And then toxic, medication induced. So those are kind of the big, broad categories. Normally, kind of barring idiopathy, you're dealing with systemic inflammation or inflammation that's just affecting the eye or secondary to an infection. So those are the kind of main things that you can get. And then within the classification, again, what's quite useful for us really when we get referrals, you know, there are various grading schemes which I encourage you to kind of get familiar with, so you know when you're saying from 0 to +4 what you actually mean, and same for the flare. So these are kind of nice explanations from the SUN working grading system. And other things to kind of mention is, as I said, take a detailed history. So rash, again, is important. You can get that in conditions such as syphilis or sarcoid and erythema nodosum. So if you've been diagnosed with one of these things, it can help us a long way. Psoriasis is associated with inflammation. Loss of hair, alopecia is associated with Harada disease, or kind of loss of eyelashes. Nail pitting in psoriasis. So, you know, things like that does help, because it could be that this is the first manifestation of the systemic condition that's presenting with the eye. Or actually, the eye might be the first thing that shows up, and then you can look at other symptoms and actually diagnose them systemically. Apart from that, the other thing is, well, decide whether it's granulomatous or non-granulomatous. Again, granulomatous inflammation is typified by presence of mutton fat KPs on the endothelium, and you can't really miss those. And often that means that there is some sort of systemic association when the condition is granulomatous. You can talk about onset of disease, duration, and the course. So, you know, is it sudden onset? Has it been grumbling for a long time? That can help you identify what kind of condition you're dealing with. Anything that's persistent, i.e. more than 3 months, is important, or recurrent. We kind of think about uveitic conditions that happen more than 3 times in a year, which would require kind of ongoing treatment, maybe even maintenance treatment. And then really deciding on how you're going to try and distinguish whether this condition is caused by a systemic condition or infection. And that's where the history becomes quite important. But when you're referring, if you mention anatomy, where you find it, and then kind of how you would kind of classify the inflammation, i.e. granulomatous, non-granulomatous, how much anterior chamber there is, flare, that can all help us decide when we need to see the patient. And those are the easy bits, because actually later on, what you will gain with experience is you start recognizing patterns, and you start seeing kind of how various conditions present with inflammation. And I'll give you some examples of this as we are going through. So it's very important in particular to notice your patient demographics, location of the inflammation, duration, onset, course of the inflammation, character of the inflammation, i.e. inflammatory cells, is there any evidence of granulomatous disease or not, and etiology of the inflammation. For example, in anterior segment uveitis, most cases are idiopathic, as I mentioned, and sterile. So you're not likely to find anything, and that's why we don't investigate the first one. But as I mentioned to you, you must look at the back of the eye. And most of you, if you do have an OCT, you should have an OCT as well, because even if there is no posterior segment involvement, you can still get macular edema with just pure anterior uveitis. So please, on your first time, do a thorough examination, do OCT of the macula. Half of the cases of anterior uveitis are actually linked in somehow with HLA-B27. So if they do present recurrently, we will be checking out for that HLA typing. Intermediate uveitis, which was inflammation that affects the vitreous peripheral retina and postplanitis, actually presents about 15% of all uveitis, and it is associated with conditions such as sarcoidosis, multiple sclerosis, Lyme disease, syphilis, and TB. So actually, if somebody has intermediate uveitis, that would make me much more worried there's some sort of systemic condition. So within your history, if you see that, you would ask about neurological symptoms, you'll ask about chest symptoms, you know, with Lyme disease, have they been, you know, anywhere where that's prevalent? and TB contact with somebody who might be at high risk. So these are all kind of important things to establish within your history. And the chief complaint actually with intermediate uveitis often is floaters. So if somebody has floaters, what would be unusual about this is you won't just see it like a simple PVD. You will see multiple, vitritis, golf ball lesions in the vitreous, and that would make you worried that something is going on systemically. And posterior uveitis can have devastating consequences. You must make sure that you are locating where the lesions are. That's kind of quite important. Are the lesions near the disc? Are they around major vessels? Or have you just about noticed something very little in the periphery? And again, that's important when it comes to us deciding when we need to see these patients. Another important thing to realize that often presence of macular edema would point you towards an inflammatory condition, just as with bilaterality. So a bilateral condition would make me think more towards an inflammatory condition, especially if there is macular edema. Unilateral condition and no macular edema makes me think more about infective. So good to kind of remember these. And then we're going through kind of the history. So age, so that's pretty important. So juvenile idiopathic arthritis, toxocaria, retinoblastoma, things like that are obviously seen a lot more commonly in children. Conditions such as Fuchs, heterochromic iridocyclitis, inflammation associated with MS, Behçet syndrome, Postplanitis, AMPI, all these things are seen more in young adults. Ankylosing spondylitis, Harada, birdshot, again, more in middle-aged patients. And TB and syphilitic uveitis can happen at any age. So these are kind of, by mentioning the age, that kind of helps us to think towards the pattern and how kind of where this thing might be going. The gender is also important. Again, uveitis with Ankspon, Behçet's, and arthritis occurs more in men, whereas JIA occurs more in females. So where the patient's from, so HLA-B27 associated arthritis are more seen in Caucasian patients, in particular those who would have ankylosing psoriatic arthritis and reactive arthritis. Sarcoidosis, for example, is seen more in Afro-Caribbean patients, Harada disease in Asian patients and American Indian descent. And then the Behçet syndrome more amongst the patients who are on the Silk Road from China to Turkey. But so most uveitic conditions don't have a particular gender or racial predilection, but it is important to recognize that so that we can try and understand if there is a pattern here to be seen. Always very important actually to ask about sexual habitus, and that can be quite a difficult conversation, especially if you're in clinic. You've got somebody young who happens to be there with their partner, or they come with a family member, and it is difficult, but you must try and establish that in a very sensitive and quiet manner, because sexual related disorders can of course predispose you to inflammatory condition, and a typical example would be immunodeficiency as a result of HIV and AIDS, which thankfully is much, it's not seen as much now because the treatments are very good. But of course, 10 years ago, they were much more prevalent. So that will help you for CMV retinitis. And actually, some of these conditions are quite tricky because, if you have got immunodeficiency in form of AIDS, then your body won't react. So often there are an incidental finding, which is why we used to routinely see anyone with CD4 count of less than 50 in clinic to check whether they are getting retinitis. And that's because the body is unable to mount an inflammatory response. And so they won't present with the typical redness floaters that the immunocompetent patient would get. So it's pretty important to notice that. The other big statistic really is that, patients with syphilis, something like 40 or 50% of them have also HIV. So, it's important to know that. Geographic I've never seen one of these, but histoplasmosis, which is associated with the Mississippi, Ohio, Missouri River. And then we've got a condition which is presumed ocular histoplasmosis, which is a similar thing, typified with lesions around the disc. And but they've never found actually histoplasma in the blood of these patients, but it's got the name. And family history, as you can see, with Angstbond and some inflammatory bowel conditions. Social habits. So you ask about pets, ask about eating undercooked meat. That could kind of point you towards, toxoplasmosis. And then we've kind of mentioned the exposure to contagious disorders. So leptospirosis infection, which gives you inflammation in sewer workers, STDs, and IV drug use, actually. So those are kind of your typical questions that you must ask, even if you feel that it's awkward. Just make sure you do it in a very sensitive manner, because that's the kind of information we need to know when we see someone. Travel, well, I don't think in the last 2 years anyone's gone traveling, but that is quite important when things pick up again, and certain regions in the world are associated with various inflammatory disorders. For example, with Brazil and Zika virus and West Nile virus in Africa, and they can present with kind of very unusual looking inflammatory conditions, which can model us for months and months before we finally diagnose them. But if you know the history, that can help you a long way. And occupational, what do they do for a living? So brucellosis in livestock workers and those who work in a slaughterhouse, etc. So age, gender, race, sexual habitus, where they are from, family history, social habits, travel, occupation. All these things should be important within your portfolio of questions. And then within your symptoms and signs, you all know about photophobia and redness as chief complaints. Pain can be very variable, actually. So some inflammatory conditions, there's no pain at all. Intermediate uveitis, for example, presents with floaters. Fuchs, heterochromic iridocyclitis, is a white eye, which you find incidentally with presence of posterior subcapsular cataract and heterochromia and some cells in the AC. Again, no pain or redness there. But I could going anterior uveitis, or somebody with endophthalmitis, of course, will have very significant pain. Blurred vision, that can occur for a multitude of reasons. Most patients with uveitis will have blurred vision. Some with anterior uveitis patients will come to you before inflammation is developed, and they are kind of your season ticket patients who know it's coming. And when they come to you, you can't see anything. The eye doesn't quite look red, but you see them the next day and the inflammation has started. So with some of those patients, we tend to trust if they're very sensible, and we get them to start steroids if they know it's happening. Although, of course, you shouldn't do that if you don't know the patient. So my advice would be never to start a patient on steroids in primary care unless you know what you're dealing with. So blurred vision can happen from high intraocular pressure, cystoid macular edema, pressure might be low, vitritis, choroiditis, retinitis. All these things can affect your vision. And floaters, we mentioned in intermediate uveitis. And of course, you look at the blood vessels. So is there any vasculitis? Is there inflammation which is affecting the venous side, arterial side, or both? Because that can actually differentiate amongst various disorders. For example, sarcoidosis, you tend to see venous involvement. With conditions such as SLE or PAN, you tend to see arterial involvement. So you need to kind of try and see what vessels are affected and how they're affected. And then really you could have looked for signs of uveitis right from the ocular surface right to the back of the eye. So you look for optic nerve inflammation and all the other kind of things that I mentioned to you. So is there circumciliary flush cells, presence of flare? Try quantify that, quantify the vitritis, and then look for lesions in all the layers in the back of the eye. Posterior synechia is something we see. A lot of people get very excited about it. These kind of, obviously, we try and prevent patients getting posterior synechia by giving them dilating drops. No one uses atropine anymore. That was the thing they used to use before. And in fact, the problem with atropine was that even you had inflammation, it dilates the pupil to a point that it kind of really fixes it, whereas you want a little bit of motility. So most patients, most people would now use, 0.5% cyclopentolate or even tropicamide to give the iris the ability to move a little bit rather than fixing it and avoiding posterior synecdoche formation. And it can be a problem because when they get posterior synecdoche and eventually develop a cataract, that makes our life a bit more difficult, but we have ways of dealing with that. Peripheral anterior synecdoche PAS, which is something you can see on gonioscopy, and I'll show you pictures of that in a minute. So pressure can go up in the eye either as a result of kind of synechial angle closure or just purely presence of inflammatory material which are blocking the trabecular meshwork. And of course, we've mentioned vitritis, snow banking, and papillitis. So here are some examples here in this picture as you're looking at the screen to your left. I've got my kind of cursor going over it. So you can see loads of mutton fat KPs. That would make me think about granulomatous uveitis. And of course, the important thing with that is that it's then associated with lots of other systemic conditions such as sarcoid and TB. And then you've got presence of cells. If any of you have never seen cells, you don't know how cells look like. For those of you who work in a hospital, go to your cataract department and you see if you can see a patient straight after cataract surgery, and you'll be able to see kind of inflammatory cells within the AC straight away. That's often quite a good time to have a look at them if you've never seen them before. And of course, do look for hypopyon. So when the anterior chamber cells are kind of really saturated, they sediment down, and we do look at hypopyon when we are looking at inflammatory response resolution. Here's a very nice heart-shaped, should use this for Valentine's actually when I'm posting, posterior synecdoche, and this happens as a result of chronic inflammation. Gonioscopy here, as you can see, the iris is pulled towards the angle, so that's PAS, peripheral anterior synecdoche, and again, example of another patient with kind of quite important closure. And it is important to treat synecdoche because if you get 360-degree synecdoche, then the IOP, then the fluid can no longer come from behind the iris through the pupil and go out of trabecular meshwork, and you can get high pressure and iris Bombay. And the problem is that you probably need to do a peripheral iridotomy in order to create another kind of place for the fluid to travel. But if they've got inflammation, the hole can close up. So it's a real nightmare to get into, and really good advice to try and treat patients with iritis aggressively. A lot of times I see patients with anterior uveitis being treated with 3 or 4 times Maxidex, and the condition is grumbling and going on and on and on. Actually, if you've got good going inflammation and you know what you're dealing with, you hit them hard initially for the first few days with very regular hourly drops of Maxidex to get rid of the inflammation, and then slowly taper them down. And that's much better than having them on for weeks and weeks of sub-threshold therapy. We've mentioned this before, so these are the snowballs. Sorry, pictures are not brilliant, but you might be able to just see them better here. So you can see kind of little white balls in the peripheral part of the vitreous. So presence of that would make you think about intermediate uveitis. And snow banking. So when you look peripherally, you just see almost like a bank of snow of white cell sedimentation. So again, quite important to be able to recognize these conditions and diagnose them quickly. Again, another example of a patient with mutton fat KPs. And these are very different to the lesions you get in Fuchs heterochromic iridocyclitis, actually, because in Fuchs, you tend to just get similar sized lesions throughout all of the cornea. Whereas with granulomatous uveitis, they tend to get bigger because of gravity. So you tend to see kind of this kind of picture with granulomatous uveitis. And again, that is important to treat. and know what's causing the effect. Here's an example of vasculitis. So often you see kind of white vessel or typically sheathing of blood vessels. I must say it's not always obvious. So that's obviously quite a, easy case to recognize. But, with some patients, we only pick it up when we're doing fluorescein angiography. So when you do fluorescein angiography, just to check if there's anything else going on, you see a lot of subclinical leakage of the blood vessels, and that's when you know the posterior segment is involved. But of course, when it's like this, then you know that something else is probably going on. And then just going back again, we are looking at the retina and the choroid being affected. So here's a patient who has very typical lesions associated with a cause of choroiditis. So serpiginous can cause like that, or sarcoidosis, syphilis can do that. Here's another picture. It almost looks as if they've had really bad laser, but these are all inflammatory conditions which have destroyed the retina and the choroid. And again, more superficial disease affecting the retinal pigment epithelium. So you can get RP epitheliitis and, inflammation of the retina to cause a lot of damage. And, of course, when you see something like that, you know that you're dealing with something significant and important, and systemic evaluation is very important. So as far as investigations are concerned, you use an under the grid for macular edema, although you'd have to have a lot of macular edema for them to notice the grid is not working very well. I use fluorescein angiography, probably one of the few causes now. I hardly use it for diagnosing wet AMD, I must say. Often you can see that on OCT, but it's very good for picking up leakage. OCT-A, of course, won't pick up leakage because it doesn't use a dye, but we do look for macular edema, we look for subclinical vasculitis, we look for a hot disc. Is there leakage at the disc, which would kind of make you think that there's involvement of all these tissues and organs. And in cases where you are considering whether the patient might have infection, then aqueous paracentesis. In fact, I no longer really do a vitreous tap if a patient, if I'm worried about a patient having acute retinal necrosis. I just do an aqueous tap and send that off to see whether they're for PCR and doing viral testing on it. The issue with doing a vitreous biopsy, and I'm saying we never do it, of course we do it for endophthalmitis and conditions like that, but if you can get away with it, it's better not to, is that you can induce a retinal detachment. So if I think somebody has probably acute retinal necrosis, then I'll do an aqueous tap. If I think I'm dealing with something much more strangely, then you might want to do a vitreous tap or even a diagnostic vitrectomy if you just cannot see anything in the back of the eye. A visual field test can be quite helpful in diagnosing papillitis or optic atrophy as a result of your inflammatory condition. Color vision, again, is important to check out if there's any optic nerve involvement. And then we can use B-scan ultrasound. So B-scan can be used for posterior scleritis. You can see this typical T sign, retinal detachment and vitritis. And the reason I mention that, I mean, with a lot of patients with good going pan-uveitis and inflammation in the front and back, is that you can't really see the back of the eye. In fact, if you're ever asked about presence or cause of an inflammation, you've got a good picture of the back of the eye, then there can't be that much in the way of anterior or posterior uveitis. Otherwise, they wouldn't be able to take the picture. So B-scan in this circumstance is quite useful in order to see if the retina is attached. Have you got posterior scleritis? So you get this typical T sign with thickening of the sclera, etc. And that can direct your therapy. And of course, OCT, very important. You can really not see edema by doing a photo of the back of the eye. You need an OCT. And I imagine most of you guys listening in probably have access to an OCT. And that will pick up, macular edema. And your kind of treatment regime changes. So you've got a patient with anterior uveitis with macular edema and somebody not, then I'm thinking about giving them a lot more topical therapy, seeing them sooner. If that's not resolving, then I'm thinking about escalating the therapy to, maybe you do a orbital floor steroid injection once you've done your investigations, or subconj if the drops are not going in properly, or if it's in both eyes, maybe oral prednisolone. So presence of cystoid macular edema is quite important to diagnose. And then really blood test in order to try and see what might be going on. So all those, as I said, most of your patients will probably not have a cause identified, and then the rest will either have some sort of inflammation or some sort of infection. So we want to check out for, and then you look at conditions. So you want to check out for something like sarcoid, you look at serum ACE and a chest X-ray. You do a TB Elliott spot test to look for TB. VDRL for syphilis, HIV. You must consent them before you do that, of course, that you're going to check them for that. If you're worried about inflammatory condition, rheumatoid factor, ANA is kind of your baseline test for autoimmune type conditions. And if that's positive, then you can try and look at other conditions, renal function and liver function, to see if other areas are involved. For example, if somebody has lymphoma, then the LFTs might be abnormal from involvement of the liver, etc. Full blood count in lymphoproliferative disorders such as myeloma or acute myeloid leukemia or ALL, and of course HLA-B27. And I mean, there are other tests here that I haven't mentioned. For example, if you've got, if you're then thinking that it looks like they might have birdshot, you do HLA-A29. So there are other specific tests you're looking at. But before kind of ordering every investigation under the sun, you would have seen the patient, taken a good history, looked at clinical examination, see what pattern it fits you, and then you direct your investigations accordingly. So imaging, as I mentioned, chest X-ray, if you're worried about sarcoid or TB, MRI scan in patients with multiple sclerosis and neurosarcoid. Actually, MS and neurosarcoid can be quite difficult to differentiate. Most people kind of don't think of MS causing inflammation, but it can present with intermediate uveitis. And MRI scan can find it difficult to see if somebody has MS or sarcoid. But if you've got retinal involvement, vascular involvement of the venous side, etc., that would make sarcoid more likely. But they can be difficult to differentiate the two. And I've already mentioned the B scan. And then, sometimes you go for kind of more aggressive vitreous or AC tap, diagnostic vitrectomy, and other biopsies in order to see what's going on. So a big question that often I get asked by juniors is that, do I have time to treat? And that's a very important question, because sometimes you think that you see this patient in front of you and you haven't got obviously any of the investigations, you haven't done the bloods, chest X-ray, etc. It can take 2 or 3 days to come, and you're thinking, well, can I start treatment, or can it wait basically until I get the investigations? And then, the way you deal with that is you've got to ask yourself, can you see a pattern? Is this systemic? Is this local? Is this part of a systemic syndrome? So your patient comes in with, oh, I have been diagnosed with Behçet's syndrome, and now your eye is gone, then actually you need to treat it. It's probably related to Behçet's, or somebody with sarcoid who comes in. Or if they've got nothing diagnosed at all, and it's just the eye, you've got to think, does this look like something that's just affecting the eye, or are other parts of the body involved as well? So apart from kind of pattern recognition, the next question is the optic nerve or the macula involved? And that's often quite important, because if you've got involvement of the macula or the optic nerve, then often, unfortunately, you are against time and you need to treat them sooner than later. What's the current vision? If the vision is fairly good, the inflammation is peripheral, not central, and you may find that then the likelihood of irreversible vision is low, then you might be able to have time to investigate the patients, but otherwise you might have to proceed. And if you think that most of your investigation, most of the bloods will be back within 24 hours, chest X-ray, again, back within 24 hours, but some of the other specialized tests like ACE, ANA, things like that can take 3 or 4 days. So you've got to think whether you've got time. And one of the other things that I would do almost immediately is if I thought somebody has endophthalmitis or if I think they have acute retinal necrosis, then I would very quickly take them to theatre and do an aqueous tap with injection of therapeutics into the jelly. So those obviously are that's obviously pattern recognition. For example, post intravitreal injection, 3 days after that, they come with, pan uveitis looking like picture. That's you recognizing the pattern that this is likely to be endophthalmitis. So you take them to theatre, do a vitreous biopsy, and put antibiotics in. Or somebody who has shingles, and then they present with floaters, and you look at the back of the eye, and you've got confluent retinitis in the back of the eye, and you think, right, this looks like acute retinal necrosis, aqueous tap, injection of Foscarnet, and oral ganciclovir. So really recognizing patterns, I can't really say more enough about it, that you need to have seen enough patients to recognize what's coming or know when you need to worry. But these are the other things to recognize when you are thinking treat or not treat immediately. And often my first question is that if I think that they need immediate treatment, can I give them high dose oral prednisolone in order to dampen down the inflammation? And you would do that if you're confident that it's unlikely to be infective. Even if the condition is infective, oral prednisolone is probably initially going to is going to treat the inflammatory side of the infection. And then, of course, if you don't put the antibiotics in, then the infection will go rampant and you would have lost the game. So often with patients where there is vision loss, optic nerve involvement, macular involvement, you think that there's irreversible damage, you probably start off urgent steroids unless you think there's a very strong infective element. And if there is infective element, then you need to cover them. So azithromycin is quite a good drug to use in order to, and it covers you for toxoplasma. Valacyclovir would look after the herpetic infection. And you might even start them on an antifungal if you think something like that is going on. But, the 2 or 3 conditions where you have to be very careful not to start oral prednisolone without any cover, and that's fungal endophthalmitis and primary toxoplasmosis. Those conditions you must have cover. And if in doubt, cover them with the antibiotics if you're starting steroids, because that will avoid things going really bad. And sometimes, they come to you and you can't see anything in the back of the eye, you're not recognizing the pattern, you might just have to go in and do a diagnostic vitrectomy, remove the vitreous and see what's going on in the back of the eye. So here I've got a patient who's got these golf balls in the vitreous. If this wasn't a Zoom meeting, I'd be asking people. So you can see a very hazy back of the eye. So there's a good inflammatory response in the vitreous. And this patient would be your typical patient in ITU with lots of lines, and hopefully you would have diagnosed, Candida endophthalmitis. So this patient needs antifungal treatment urgently. And then this patient would present with area of retinitis acutely, nothing else going on, recent, contact with uncooked meat. So you think about primary toxo. And you're against time here because the macula is involved, so you need to start treatment on them quite quickly. And we used to use pyrimethamine, sulfadiazine, and folinic acid to treat these. Now you can use clindamycin to treat them. And you also, along that, once you've got a bit of antibiotic, and you need to treat them with a bit of oral prednisolone to get the inflammatory response down as well. And at the bottom of the picture, this is very typical of viral retinitis, where you've got this confluent retinitis affecting all of the back of your eye, and it's really growing in, and you're against time with that, and it leaves this paper thin retina which can break off and cause detachment. So very important to treat patients. Often we would do an AC tap, treat with Foscarnet intravitreally, and then you give them oral antivirals, which has good bioavailability, like the intravenous ones. And then, sometimes I've written here, you have time. So this picture, the nerve and the macula are not involved. So this patient, you don't have to rush. You've got, hemorrhages in the periphery, you've got a bit of vasculitis, so you're thinking maybe this could be sarcoid, something like that, and then you have time to do your serum ACE, chest X-ray, etc., and wait for the investigations to come back. So that's very important to know what you are kind of dealing with. And then you got to plan for the future. So inflammatory conditions, if it is systemic, then you've got to think about other systems. So if it's the first time that you've seen it and you think it might be Behçet's, you refer them to the center. Often, if it's a significant event, like a vascular occlusion or something like that with the inflammation, then they will start the patients on high-dose immunosuppressants. Otherwise, next time they could have a stroke if you're worried about Behçet's. So it's important to do that. Or if you've got tertiary syphilis affecting multiple organs, and then you're seeing something in the eye, then you need systemic treatment. So do think about who else you need to involve with these. And always, if you're starting with these oral prednisolone, you think the condition is chronic, ongoing, or systemic, then you need to get them off these systemic steroids, and then you're thinking of second-line agents. So you must have a good rheumatologist or physician within your practice to collaborate with, because they would know how, what drugs to use. And increasingly, we are now using biologic agents, which have, a whole host of side effects. So it's important to do that and involve them in support groups, because nobody really thinks about that. But these patients are often looking down at chronic ongoing treatment. Sometimes it's only the eye that's affected, and yet you are putting them through very large quantities of immunosuppressants, which can affect them otherwise. So please do think about that when you're managing these patients. I just wanted to talk about kind of Coviden Uveitis. So this is probably a bit more important before everyone was vaccinated, but there was a lot of worry about systemic immunosuppression in patients, and of course risk of them getting COVID and that affecting them. So there was a lot of kind of discussions amongst the uveitis community on how to manage these patients. And of course, you couldn't see the patients or assess them. So this was becoming very tricky. So we locally kind of managed what we could virtually, by calling patients and seeing how they were. We, of course, gave them a face-to-face if it was a new case, as that it might be time critical. If it was involving the nerve or the macula, or if you thought they might lose vision, and you just take care. So everybody had PPE, and we kind of deferred anything that could be elective. So all those patients with inflammation or cataract, that could wait. They would wait. And we carried on with urgent care, like most places. I said uveitis is one of those conditions that you can't let go. And really active, non-effective uveitis, which was not responding to topical therapy, you would kind of think maybe systemic immunosuppression. And we involved the physicians with our decisions, as immunosuppression could have affected them if they were getting. A lot of these patients were self-isolating and were in the at-risk group, so they weren't actually going out, kind of doing stuff. But it was important to say that we actually saw probably a third or a quarter of the number of patients that we used to see in clinic with these conditions. And it's amazing how much people would things back initially during the first wave. And now we are seeing the sequelae of all these patients who've unfortunately been waiting and getting treatment. So the doors were always open, and still, if you need to immunosuppress patients, despite all COVID and no COVID, you must do that to save the eye. But of course, you involve physicians and you give them the appropriate advice on what to do if there were concerns about self-isolation and things like that. And I think I kind of wanted to finish off by saying your 8 steps for managing uveitis patient is review symptoms, look at the pertinent signs, kind of review the history and systems and see if there's any pattern you can recognize, clinical examination, classify the uveitis based on its location and severity, granulomatous versus non-granulomatous. You think about what lab or radiological studies are necessary. I know that for most of you who don't work in the hospital, that'd be outside your remit. and aggressive treatment of intraocular inflammation and appropriate referral. So really kind of my few pros, if you're going to remember anything from today, is that anyone with uveitis, you must perform a full dilated fundus exam and do an OCT to check for macular edema. Always refer these patients on. Don't kind of sit down. If you're worried that they have uveitis, they must have an urgent referral. Within the referral, it's very important to try and give as much information as possible, because you think about the doctor who's triaging or the nurse who's triaging, and they've got to decide whether that patient needs to come in or not. So, you know, onset of symptoms, severity of cells, which layer is this affecting? Is this the first time? Any medical history, any medical diagnosis that they've been made of, any recent surgery. And all these things are kind of really important for us to decide when to see the patient. And from our end, the first thing I do after taking a history and examination is to think, can I wait, or do I need to do, can I do my investigations and then start the treatment, or do I need to just start with oral prednisolone and cover them with some antibiotics and hope that you're not making them worse while you're waiting for the investigations to come? And then long term, warn the patients. We always warn them that, look, you know, this is just the beginning, and there'll be other kind of therapies to come in to dampen down the inflammation if the condition is chronic or if it's associated with a systemic disorder which will be ongoing. And they'll be looking at second-line agents or even biologics, which would mean that they'll be in clinic for often the rest of their life, unless the condition kind of burns out. But often these conditions can be ongoing. And that's it. There's probably, you know, if you can get to a uveitis clinic, it's always quite a good way of getting some exposure to recognizing these patterns. Now, Purvi, are you going to come on? I think, what time is it? I've done.
It is.
Yeah.
Thanks, Shah. That was absolutely fantastic. Would you mind just if you stop sharing the screen, if that's okay? Thank you so much. So we're going to start with questions. The first one, Shah, could you please tell us, when we're looking in the eye, how we differentiate between cells, flare, and snowball?
So cells and flare is kind of what you see in anterior segment. Snowballs are what you're going to see kind of in the anterior vitreous, more kind of inferiorly. So when you've dilated, you look with a 90D, and if you kind of get them to move the eye around, when you're looking inferiorly, you can see these kind of snowballs. Picking up cells, you need to kind of separate so you've got your viewing bit and the kind of the light coming across. I would switch off the light in the room and bring the viewing light to kind of the smallest, but go on brightest. And then you just, I would probably, go on the iris, get the iris in clear view, and just move back from the iris. And what you can see with the cells is that the cells at the front should be coming down, and cells at the back towards the iris should be going up. And that's quite a good way of noticing which ones are the cells, because you've got the, I can't remember the name of the term now, but you've got this phenomenon where because of the heat of the blood vessels on the iris, the cells kind of float up. And when I come to the front of the anterior chamber, because it's cold, they go down. So you've got this process. And the flare is just kind of, within my talk, there was a slide which showed you how you kind of diagnose and differentiate flare, which in essence, you're looking to see how visible the iris is, and you grade it from 0 to 4. So it's kind of just, it just looks very different to cells. Cells are just like tiny white dots which move around, and flare is just kind of, I don't know how to kind of measure this, like dust. They're much smaller and finer in quality. But as I said, if you've not seen it, if you work in a hospital, just go to, when they do cataract surgery, straight after cataract surgery, you'll be able to see them on a slit lamp, and you can see the cells just going round and round. So the snowballs are seen in the anterior vitreous.
Thanks, Shah. Next one, and acute anterior uveitis. Choice of steroid and dosage and frequency, please.
I think if you are happy, it's the first episode, anterior uveitis, back of the eye looks fine, no macular edema. I would probably hit them hard with hourly or 2-hourly Maxidex and cyclopentolate 0.5% twice a day for the first 2 days. And then after that, you can taper them down from 6 times a day for a week, 5, 4, 3, 2, 1. The cyclopentolate can stop when the inflammation has stopped. So probably carry on for the first few days, maybe a week. And then when you see them after a week, do the pressure, make sure the pressure is okay. And if the inflammation is resolving or very much resolved, you can stop the cyclo, because they can be quite, it can be quite annoying when they go out with the cyclo and stuff. So, and then just a very slow taper of the Maxidex over a few weeks. If it does rebound, then you need to start the process, but maybe more slowly taper. And if it's a second occurrence, then they need investigation.
And Shah, in terms of recall, if we're seeing it for the first time, at what point do you bring them back after the first visit? So we start them on the drugs, and when do we see them back in clinic?
Yeah, I mean, I would probably say that you want to see them within a week to make sure that the pressure is okay, because that's quite important. Some patients have steroid response, and if you leave them for weeks, they could come back with a pressure of 40, 50. So, see them after a week, and if after a week they're okay, then you can slowly taper them down. But initially, as long as the back of the eye is fine and everything is okay, I would say for the first 48 hours, you go a bit harder and then taper that down from 48 hours slowly. What we see often is that patients are starting on 4 times a day, and then 3 weeks later, they come back and they still got this grumbling inflammation. So go hard initially and then taper down more quickly.
And if we do see them back after we've tapered them down and they have rebound, we start them back on the original dose of hitting them hard, or we just take them up a little bit?
Yeah, no, then you just, you go back and, I mean, one of the things at that point is to think, why is the inflammation not settling down? So I think, if you can't get them, beyond, I don't know, 4 times or 3 times a day and the inflammation is coming back, you need to think what's happening. So at that point, I would probably make a referral. For example, we see this sometimes when there's a very small lens fragment retained somewhere after cataract surgery, and they come back, they keep coming back, you keep giving them course of steroids and it just never goes away. So I think at that point you need to think what's going on. But it's not unusual for the first course of anterior uveitis, it goes away, and then 2-3 days later it could start. You repeat the process, and if you feel that you're not able to get them off the steroids, then you probably need to look for a secondary cause. I would only not refer or investigate anterior uveitis if it happens once and it goes away completely. If it keeps coming back, you need to look into it.
Thanks, Sean. On that subject, sometimes you get people that know they get anterior uveitis and they often treat themselves. If they come to you and say, I think it's coming along, and I've had it before, but you have a look and there's nothing there, what do we do then? Do we send them to the eye hospital?
Yeah, it's difficult. I mean, I think you just have an honest conversation with them. So those with recurrent anterior uveitis are probably under a specialist, and the specialist would have known whether they're okay to start using steroids if they feel it's coming along. I always say that they need to be seen, because you can't always assume that it's anterior uveitis. What if it's something different? So I think if you don't know the patient, I wouldn't start steroids, because you don't know the patient, you don't know them, you may not feel confident what they're saying is correct. So if you don't know them and you can't see anything, don't start. But as I said, those with recurrent, they know it's coming, would often have had repeat prescription, and it would have been okayed by the department for them to start, but they would almost always have access to the department to get checked out like the next day to make sure they're not treating something they shouldn't be.
So if we do see someone like this in clinic and they're not going to the hospital on the same day, can we give them some cyclo or tropicamide?
Well, without giving them steroids. I mean, I think if you've got someone with good going anterior uveitis, really red sore eye, I would want them to be seen that day.
Okay. Post cataract, is it normal or expected to see a few cells after 4 weeks?
Yeah, I mean, that can be annoying. That can be annoying, can't it? Because you think what's going on. Yeah, I think as long as the eye is not red, they're completely symptomless. Everything is fine. You just see 1 or 2 cells here and there. You probably need to just warn them that look, come back if this problem goes on. I probably wouldn't rush retreating everything unless you think that is significant. But I would, if you're not happy that the inflammation is completely healed, maybe just get them back in a few weeks just to make sure that it's gone, with a view to see them if it goes up. I think there's a difference between just seeing the odd cell here and there than +1 cells, which I would say is still ongoing. And in a lot of patients, you stop the steroids, they are fine, and then they'll come back and say, oh, actually my eye started going again and the inflammation started again. So then you have to, then I think if it's restarted again, you have to do the whole course again, and you taper down over a longer period of time.
Thanks, Shah. I have an IP optom, independent prescriber, who says that their hospital protocol is to refer a first presentation of uveitis, but as an IP, we can actually manage it ourselves in clinic. So are you saying that actually optoms are quite okay to manage a first occurrence of uveitis?
Sorry, no, what I meant was when I see a patient in clinic and it's the first episode of uveitis, I don't investigate. I didn't mean, sorry, it's a good point to clarify. If you see them in practice, you must send them in. Unless you have got the right qualification to be managing uveitis. I'm not.
As an IP optometrist, we can actually manage.
You can manage it.
Mm-hmm.
But whether would that then give you have you got the tick to go through all the systemic history, investigate to see whether somebody needs investigating or not? So what I do in a hospital setting is when I see the first episode of uveitis, I don't order blood test, is what I meant to say. I mean,
Okay.
Obviously treat the uveitis, but I don't order blood tests or investigate them. But if it's recurrent in any way, then of course they go through the whole process of being investigated. So as a practitioner, single referral, single episode of anterior uveitis with no posterior segment involvement, no macular edema, nothing, you don't need to do blood test. But if it's recurrent, then you do. Now, if the regional protocol says you must refer in, then you must refer in. But our protocol locally is the first, anterior uveitis, you don't need to investigate.
So I'm just going to go through a couple more questions, if that's okay, because we do have a few. So just a few more. On the change topic, we're talking about chorioretinitis now. Okay. How do you know if something's an active case or if it's an old case?
Yeah, it's a good point. So I think, first of all, you look for other signs of inflammation. So is there any anterior chamber activity? Vitritis is very important. Is there any vitritis? If there's no AC or vitritis, AC activity or vitritis, then it's likely that it's all looking chronic. Now, as I mentioned to you, not all cases will have those signs. So, for example, pure choroiditis may not. So then you look to see why they're there. If it's an incidental finding and nobody's looked into it before, then they need investigating. Normally, active cases of chorioretinitis would be associated with inflammation. So there'd be some vitritis, there might be some AC activity, there would be macular edema, those things would be present. Once everything's treated, of course, the scar tissue remains behind. So fresh lesions often don't have pigmentation around them. So you can just see these kind of white lesions in the back of the eye, but there's no pigmentation around it. And that's how you kind of see. So having photos would be quite important. So if they've had photos in the past, you download a photo and you see more lesions showing up, means that the condition is progressive. So ask for any new symptoms, look for signs of AC or vitreous activity, look for vasculitis, look for macular edema. And as I said, if they have never been told they have it, then you must investigate it. That patient that I saw was sent to me with diabetic macular edema, and the person who'd seen it, who actually was a consultant ophthalmologist, had thought that they'd had previous laser treatment. And when I initially looked at it, I thought, oh, you've had laser treatment. And she said, no, I've never had laser. But she had these most amazing, very symmetrical lesions, which just looked like PRP marks. And she ended up having birdshot chorioretinitis. So I think if you've not seen the patient, it's very difficult to know, because new lesions can only be picked up if you've got a previous picture to look at. But if there's, if you're essentially looking for symptoms or signs of active inflammation, which I just mentioned.
Actually, I'm going to give you the last question. Actually, I'm sorry to those that I haven't answered, haven't asked and haven't been answered, but on the, how do you differentiate between active and old keratic precipitates?
Well, I mean, it's not so much that you're differentiating between active and old KPs. You're just saying what the state of the eye is. I mean, you know, so we see KPs in, as I said, you can see it in Fuchs, heterochromic vasculitis, which you know, the uniformly in the back end of the cornea. With mott and fat KPs, they're kind of more concentrated inferiorly. But you're just, what's more important actually, is there active inflammation now? Is there AC activity in cells or flare or not? KPs can kind of will remain there forever. I mean, initially when you treat them, some of them might dissolve, but a lot of them might stain and remain there. So what's more important is to see whether the eye is currently inflamed or not.
Thank you, Shah. I'm afraid that there's no more time for the questions. It's been absolutely fantastic. I am just going to launch the poll. So everybody, if you could please just answer the questions, just so we can get some feedback on how these webinars are going. And thank you to everyone who has sent messages to me or emailed us with feedback of the webinar. They are greatly received and much appreciated. And any further feedback or topics you'd like to hear about, I'm always welcome. Happy to have a look and put them towards the guys and see what they can come up with. And also, I just wanted to say a few of you have popped into clinic to see some of our consultants for your own eyes, and it's been lovely to see you. So if you are ever in New Cavendish Street and you are coming to see one of the consultants, please do ask me, as you have been, and I'll be happy to come and say hi and just give you a tour of the place if there's time, but definitely just at least to come and say hi and have a quick chat. It's really nice to see you in there.
Can I just, I've just seen a very good question, if you give me 1 minute.
No, go for
it. The question is from Anand, who said, how do you perform a surgery on a patient with uveitis episode? Which I think is very relevant. So cataract surgery and uveitis. In a patient with uveitis, you want them to be free of any inflammation for about 3 months before you do the inflammation. You should never operate on a hot eye. So if I've got someone with uveitis, I'll make sure that they're completely free of inflammation. And if you've got them in that stable position, then you start them on the week before surgery on maybe 40 milligrams of oral prednisolone. And then you do the surgery and you whack up maybe the oral prednisolone a bit more and then just slowly bring them down, as well as the topical drops. Otherwise, the uveitis will go haywire. So that was a very good question. If the inflammation is ongoing, then it's a lot more complex, and that will be a lecture on its own. But generally, before you do routine cataract surgery on somebody with inflammation, you want them to have not had an inflammatory episode or have active inflammation within 3 months.
Thank you so much. And Shah, just finally,
yeah,
I am going to share my screen actually, just to talk about the next webinar that we have. So everyone that has seen these webinars before, you know about our referral portal. I won't go through it. You can find it on our website, or the link's right there if you want to directly refer to us. The portal is safe, secure, and GDPR compliant, so you can enter as much or as little information as you want. You can add your own scans, your own referral letter, and we will take care of the rest. Our specialties, as you know, we do most parts of the eye now. Actually, we've got Shah, who is part of our retinal team, along with Chen and Lorenzo. We've got Susan in oculoplastics, Sally in glaucoma, and then we've got Ali, Aaron, and Wamesh, who do anterior eye laser cornea. This is our WhatsApp group, which are great for case studies. The consultants do post fantastic case studies on there on a weekly basis. So if you'd like to join, that is a QR code for it. If you can't access that right now, just drop me an email and I can get you added onto that group. I hope I've left this on for enough time. I do get a few messages afterwards saying I didn't, and I didn't give people enough time to add themselves to the group. And finally, our next webinar is by our very own Sally Amin, and that will be Thursday, the 27th of May, again at 8 p.m. And she will be talking about glaucoma, what's new in and out of the operating theatre. So that's bound to be another fantastic one. And that is a QR code that takes you straight to the registration page if you're keen to do it right now. Right, that's it for today. Thank you so much for joining, Shah. Thanks so much. That was absolutely fantastic. Much
You're welcome.
appreciated.
Thank you. Bye.
Bye, everyone. Bye-bye. Have a great evening.